My name is Leslie Arnott, and I am the Consumer Partnerships Lead for the Women's Health Research Translation and Impact Network, affectionately known as WRTN because it's too much of a mouthful to say otherwise. And I'd like to welcome all of you today to this session entitled There's Diversity in Diversity, Working for Success, Consumer and Researchers in Dynamic Partnership. But before we go any further, I'd like to introduce Shona Kennedy, who is a proud Gamilaraay woman who is going to do our acknowledgement of country. So take it away, Shona.
Thank you, Leslie. Hi, everyone. I'm Shona. We acknowledge the Aboriginal Torres Strait Islander people as the custodians of the lands on which we live, learn and work, and we pay our respects to the elders past, present and emerging. We especially take this time to recognise and honour Indigenous women who are here, as well as those who have gone before us. We look to their collective wisdom in guiding our work and seek continued partnership as we work together to improve health outcomes for all women living in this land. Mandangu.
Thanks so much, Shona. That's fantastic. So on your screen, I'm so pleased to invite these speakers today. I'm very excited about this session. We have Dr. Rosalie Power from the Translational Health Research Institute. We have Dr. Mahima Kala, who's from the University of Melbourne's Digital Health Validitron. Shona, who you've just heard from, manager at Woolloo Health in Bathurst. And also those will be our three speakers. And then we have Professor Jeanette Pers with us too, who will join us on the panel Q&A session that follows the three sessions. So just to talk a little bit about this session today, you know, the theme of this webinar is There is Diversity in Diversity. And you'll hear from our speakers today about the various diversities within diversities that they experience in their present and past work, and how perhaps it's incumbent of all of us to be aware and embrace the multifacets of every single individual that we work with in our co-productive and community participatory research projects. It's so important to consider all of those things. So we are not just one thing, that is for sure. And you'll hear from our speakers that indeed we need to take those things into account if we're actually going to deliver research that is community relevant, that is equitable, and that embraces all facets of all of our varying communities right across Australia. So without further ado, I would like to invite Dr. Rosalie Power to open up this webinar today with her presentation and her insights with some of the project work she's been conducting over the past year and a half. Rosalie, take it away.
Thanks, Leslie. So hi, I'm Rosalie. I'm a research fellow at the Translational Health Research Institute, and today I'm going to talk about a study I'm leading called Across the Margins, which is about the sexual health of LGBTQA+ people with disability. It's a co-production project, and we have a huge investigator and advisory group, about 27 people who are informing and shaping the project as we move through each stage. So our team includes LGBTQA+ people with disability, academics, many of whom are also LGBTQA+ people and or people with disability, disability service providers, sexual health care professionals, as well as ASHM, Family Planning Australia, Participate Australia, and Women with Disabilities Victoria. As I talk about the project, it'll sort of become apparent why we've got so many people involved, and that's to do with this idea of diversity within diversity. So why this population? Well, LGBTQA+ people are often talked about as a minority within a minority. But if we look at the numbers, this is actually a pretty substantive population. So about 18% of Australians have a disability and 5 to 16% are LGBTQA+. So if you use those figures alone, that's just shy of 740,000 people with LGBTQA+ people with disability nationally. And those figures could actually be higher because we know that rates of gender diversity, for example, are higher among autistic people. both people with disability and LGBTQA+ people report unique threats to their sexual health. So this is a really important topic to be looked at, and especially when we're including both of those intersections together. Throughout history, the sexuality of people with disability has been controlled, suppressed, pathologized, and denied, with discourses of risk used to deny sexual rights and freedoms, perpetuated by systemic oppressions and fueled by ableism. So this tends to portray people with disability as unfit for sexual relationships, marriage, parenthood, unable to control sexual urges, and those with uteruses incapable of managing their menstruating bodies. So these are really harmful beliefs, and they've had really far-reaching consequences, including for people who are also LGBTQA+. They're dehumanizing, and it's permitted state-sanctioned violence, including sexual segregation, forced and coerced sterilization, and things like menstrual suppression, which is particularly an ongoing issue for people, many people with intellectual disability. So the impacts of these types of beliefs and oppressions are even more encompassing for people with disability who are LGBTQA+. LGBTQA+ people with disability tend to face societal pressure to conform to normative constructions of able-bodied cisgender heterosexuality and report greater levels of child sexual abuse, adult sexual assault, and significantly higher psychological distress than LGBTQA+ people with disability. And there's a bit of research that's coming out that is telling us now the real sort of tangible impacts that these sorts of things are having for LGBTQA+ people with disability, including reduced quality of life, low participation in sexual health care, late diagnosis and high risk of death from cervical cancer, higher rates of STIs and HIV, underreporting of sexual violence and abuse, despite exceptionally high rates of sexual violence in this population. So there's a lot of unmet needs for this population, but they're often they're often not dealt with as a whole person, a whole community. People are often having to pick and choose parts of themselves to receive services and to receive care. So this project is aimed to understand these intersections and allow people to be their whole selves. So yeah, this slide just sort of shows a few examples of what these areas of negative impacts on sexual health are. Previous research, sort of speaking to what I've just mentioned, previous research has really been around sexual health has been quite small scale, and it's tended to focus on younger cis lesbian women and cis gay men, or people only with physical or intellectual disability. But we know actually people often have numerous impairments, their gender or their sexuality. You'll see when I get to talking about who we've heard from so far, people often hold multiple identity labels. So when we put people in these tight categories, we're often actually excluding a whole range of people, and we're also not representing the true diversity of who this population are. So to work on this project, we were really fortunate to have an incredible opportunity through Wharton's co-production grant to co-produce a research proposal. So I'll talk a little bit about how we've come to the research that we're doing at the moment. So the first step that we did is a call out to LGBTQA+ people with disability to identify a consumer co-lead and other consumer investigators who would be part of the project with us. And we then compiled a broader team of other investigators. So where we needed other expertise or knowledge, we've invited those people into the project as well. We then used an iterative sort of process, drawing on a range of methods and technologies that were responsive to our team's participation and communication needs, including using, so in our first meeting, we used a word cloud to encourage people to participate their thoughts if they could engage then without having to speak up in a meeting. We've had individual one-on-one meetings, small group meetings, whole team meetings. We do stuff by email, sometimes using WhatsApp voice notes, And we've tried using a Menti board at one point as well. That wasn't so successful, but we gave it a good shot just to try out different methods of communication that will facilitate participation from this really broad and diverse group. And you can see from this picture here, it's not a linear process. There's a lot of arrows backwards and forwards between the different steps, allowing space for people to think deeply about what we're discussing, to come back. You know, you often walk away and you think of a better thing that you could have contributed later. We're wanting to allow for that in this project. So giving people the opportunity to contribute ideas after the meeting or after we've discussed something, as well as the opportunity to change their mind. So this process takes a little bit longer than traditional research, but it's been really, really important in terms of the approach that we're using and in terms of the richness of the research. So what we came to were 3 aims. So the Across the Margins study is aiming to identify the unmet sexual health and sexual health care needs of LGBTQA+ people with disability. We'll then co-create a model of sexual health care and implement and evaluate the model of sexual health care. And it was really important to our team that we capture experiences of people with a range of impairment types across different sexuality and gender identities, ages, socioeconomic status, geographic locations, and cultural backgrounds, and that we adopt a strength-based approach. So we understand the positive impact that disability and LGBTQA identities can have on sexual health, as well as facilitators and barriers to culturally safe and accessible sexual health care. So this slide is to kind of show the steps that the project is going to go through. So the first major milestone was working out our co-production framework. So once we'd co-designed or co-produced the research proposal, we then needed to start putting it into practice. So we thought about who wasn't already represented in the team and if there were other people that we needed to invite in. And we met together for a 2-day face-to-face workshop to talk about how we're going to work together and to map out some of the key parts of the project. So I'll talk now about our co-production agreement. So we're drawing on the UNSW Disability Innovation Institute guidelines for doing research inclusively. And they have materials available in an easy read format, which means it uses simple, short sentences and phrasing alongside images to help facilitate understanding for people with low literacy and particularly targeted to people with intellectual disability. So we're really being guided by those approaches and principles. And I guess what that translates to is co-production means doing research together. And these are some of the qualities of that. So there's lots of benefits to working together. Co-production makes sure that research is about what's important to people with disability and make sure that we get data in ways that are safe and accessible for everyone. It means that we share the power and that we value diversity, different ideas and skills. We need to make sure that there is access, not just of buildings through ramps and physical access, but also of information so that our information is easy to read. And everyone must benefit from working on the project. We're really mindful that we're not just taking from consumers in this project. We need to be flexible, so we might change the way we do things. If we find it's not working, we're reflexive about that. And we need to be clear. Everyone needs to know what we're doing. So we put together this co-production agreement. It includes things like our team and roles, working together, how will decisions be made, what will we do when we disagree, what kinds of support will help people to do a good job, about the meetings, everybody in the team feeling safe, and that's particularly important around the topic of sexual health, and how will we know we're doing a good job at this. So the team all have access to this. It's in an easy read format, and we also have an audio-visual recording of it. Some people, even though it's an easy read, some people don't read so much, and so they can watch the video and listen to this document being read to them. Now, I think I've sort of overspoken, so I'm going to move through the next slides quite quickly, but Just to let you know that we're up to stage 2 of the project now, which is about identifying needs, and we're undertaking a survey and interviews as well as arts-based data collection with LGBTQA+ people with disability, and surveys and interviews with disability service providers and healthcare professionals, as well as a literature review. And our advisory team have been really actively involved in each of these steps. So just as an example of how we've developed the survey, we had an advisory group meeting. We've then had individual and small group meetings, and we've drafted things, and then it's gone back and forward between the team at different stages, really playing to the strengths of different people's participation and communication needs so that they can contribute to the look, feel, and content of the data collection materials. And the impact has been phenomenal. We've heard so far from 90 LGBTQA+ people with disability who've done the survey. And I should have updated this now. We've actually had 20 interviews completed. But more excitingly is the diversity of participant that it's allowed us to reach. Because we've been so we've included such a broad range of people into our process of developing study materials. We've captured so many different nuances and needs in the way we've presented our information. We have a huge range of gender identities represented, sexuality identities, an incredible amount of or different types of impairments that people have. People are ranged from 18 to 66 years old. About a quarter live regionally or rurally. 10% are Aboriginal or Torres Strait Islander, 10% were born overseas, and we've also got a huge spread of educational background. And we haven't done any targeted recruitment yet. This has just been through going out through our advisory group and through our known networks and inviting people to take part. So we're really excited by that and the way that we've been able to capture diversity in diversity by using these co-production approaches. So this last slide is just to acknowledge the huge number of people that are involved and yes, to say thank you for the opportunity to present. Back to you, Leslie.
Oh, Rosalie, that was just wonderful. Thank you so much. It's just a lovely multifaceted approach and environment for multifaceted people, including the researchers and those consumers that you're working with. So I congratulate you wholeheartedly on your work. It's making me smile, this last part. I mean, you started off with a sobering account of the experiences of those from the LGBTQI and the disability sectors. And thank you so much for your work in bolstering these people and making a difference. It's just fabulous. The other thing that I loved hearing too was that, you did co-design right from the very beginning, which is brilliant. And also really importantly, you embraced some principles and values, and one that was reciprocity, which I really, really love and I champion. So thank you so much for your work. I really appreciate it. And thanks so much for that presentation. It was terrific. Well done.
Thanks, Leslie. Thank you very much.
That's just brilliant. Okay, so now I'd like to invite Mahima Kala to the stage. Mahima and I work together at the Centre for Digital Transformation of Health, and Mahima's area of expertise is equity. And she's going to be sharing some amazing information, a slightly different slant to what Rosalie presented at. And if anybody does have questions, please pop them into the Q&A. And we'll address those at the end of the 3 sessions. So take it away, Mahima.
Amazing. Thanks, Leslie. Hi, everyone. It's a pleasure to be here. My name is Mahima. I'm a research fellow at the Center for Digital Transformation of Health. And within that, I work at a digital health innovation facility called the Validitron. My topic today is a little bit more theoretical and principles focused, but I would love to hear people's thoughts at the end of the presentation and certainly take questions as well later on. So today I want to talk about empathy and humility and shifting the focus and how we talk about underserved communities in our research. I know we've had an acknowledgement of country already, but I also want to acknowledge that Indigenous people have their own constructs and ways of knowing about health and well-being and what it means in terms of just the meanings of well-being and sense-making about I really appreciate their ways of making sense of health. So I just want to acknowledge that as well. Before I dive in, I want to talk a little bit about the Digital Health Validitron, just a brief overview if anyone's interested in learning more. So these are a few photos of our digital health innovation facility. We have this simulation lab where it's a physical suite of simulated spaces. So at the bottom here, we have a hospital space. Up top, we have a GP consultation room, and up here on the left is a patient home space. And in the middle, you see a control room where our human-computer interaction scientists can observe what's happening on the monitors, what's happening on everyone's screen, but also what's happening through the one-way mirrors as well in the rooms themselves. So this is a really good way to test out new digital health innovations and really simulate what could be some pain points if this technology were to be implemented in the real world. And this can be super helpful for ironing out equity-related barriers as well, for example, language issues or learning disabilities or other special needs for participants. So this is a useful lab and facility. If you ever have a chance to be in Melbourne, please do hit us up and we would love to give you a tour of the lab. And so why we exist is basically to improve implementability and workflow integration of digital solutions. There's supposedly evidence that up to 90% of new digital innovations fail when they go into the real world. So that's sort of why we exist, because we want to help make these digital ideas or products sustainable for the real world. And we do that through obviously our simulation facility, but we also have a virtual space for prototyping. It's a sandbox where we can put together the different components of a health services cyber infrastructure and really test out if we were to integrate a new technology in the health service, how would that impact workflows and so on. And certainly we have methods expertise as well, which is basically our people. So we have a very diverse multidisciplinary team ranging from co-design and equity professionals like myself. We also have things like human-computer interaction, technical interoperability capabilities, implementation science, health technology assessments, and health economics, and so on. So with that little introduction, a quick overview of my background. That's a little AI-generated avatar that I asked Canva to prepare, just as a bit of a nod to our changing times that we live in, and just trying to sort of make sense of the world as it is now. So I'm very much an interdisciplinary professional. I have expertise in co-design, as I was saying, but in the past, I've actually worked in management consulting. So academia is sort of my second career. The first one was in management consulting. But what that really helps is then bringing together diverse perspectives from lots of different people, disciplines, and lived experiences, and trying to synthesize their tacit knowledge into development of new digital innovations. So with that said, let's dive right in. I want to start by talking about digital health equity. And I say that it's a bit of a paradox because on the one hand, if you think about digital innovations, there's huge potential for digital solutions to bridge gaps to healthcare, both whether it's quality or access. So the first presentation talked about LGBT health. To give an example in the same vein, there's some evidence to suggest that LGBT people have poor health-seeking behaviors given they face barriers to access, whether it's stigma-related or other sort of issues in terms of systemic discrimination in the health system. So there's some evidence to suggest, for example, that people can get online peer support. So things like suicide ideation or mental health, peer support through online media can be very useful for these populations to get some level of care. So on the one hand, there's potential, obviously, to bridge gaps. But then on the other hand, there's also a risk that by digitization of healthcare, we exacerbate existing inequities. So imagine a rural older adult who lives in a regional area where there's only one health service 30 kilometers away. There's a very limited sort of time available for doctors. It's a very highly booked service. And then on top of that, you add layers of online bookings and so on, which then impacts a person with low digital literacy to then seek help in a timely manner. So it's a bit of a paradox where on the one hand, yes, it has a lot of potential, but on the other hand, there is risk that it can exacerbate existing inequities. So how do we then frame digital health equity? So I guess in light of what I was saying, there's two ways to think about digital health equity. Number one is outcomes, where we think about mitigating unintended consequences from our project. So that could be, for example, algorithmic biases, or like I was giving an example earlier about adding barriers to people accessing healthcare, which then causes an unintended consequence. But on the other hand, aspirationally, we want to be a facilitator for narrowing the health divide and reach groups who may otherwise face barriers to access, and certainly also improving the quality of the care that people receive as well. But then the other component is also equity in process. So equity in outcome is the outcome we get from the use of a digital technology. But what about the process? How do we actually get to the technology? How do we go about designing it, developing it, and implementing it? And so in the first instance, we want to ensure that diverse populations are represented in co-designing and prototyping. And we certainly also want to practice reflexivity about which outcomes do we actually measure. Are there certain things that we should be measuring as part of our business as usual evaluation plans? Because the idea is that what gets measured gets managed. And so also liaising with your priority communities and understanding what is really important to you, for you to measure, and for you to sort of deem this project to be a success. And also then in the same vein, do we need certain data analysis techniques? So I suppose the diversity I'm referring to is around the diversity of the research method when we design these health technologies. And another example of diversity in when we think about the digital environment is that there's different levels of influence. So this is a digital health framework that was published a couple of years ago. And from an individual perspective, we want to think about things like digital literacy, self-efficacy, technology access, and so on. But on the extreme societal end, it's about things like ideologies, design standards, algorithmic biases, community infrastructure, and so forth. Now, having shared a little bit of that sort of conceptual framing about digital health equity, it's really helpful to think about that equity in process a little bit more. So I want to do that in three categories by introducing three principles or ways of thinking, and some of these you may be familiar with, but I just want to shed light on how I've applied this in the digital health context. So the first one is meta-empathy. Obviously, you may have heard about the Stanford Design Framework or a number of other design thinking approaches where when you are developing a new innovation, the first thing you want to do is actually empathize with your end users. Now, meta-empathy is taking it one step forward, where it's saying that it's not only important to just listen to understand, but it's also understanding how is it that you are listening? What are the filters or lens you have through which you are seeing your population? So it's really helpful to illuminate problematic power dynamics and really reflecting on listening and practicing that deep listening. And really kind of trying to also understand what is the relationship that we hold with those who are most proximal to the problem. And by that, I simply mean if you're engaging with a group of participants, what are your preconceived notions about them? Have you imagined certain things about this community, or maybe you had an experience with one person of this broader population group, and have you then superimposed this entire population group with that one experience? So those sorts of things are really helpful to reflect on and really practice that reflexivity. And one way to do that is through three simple questions from this platform called Equity Meets Design. And it's called a meta-empathy map, where we may want to reflect on how is it that my identity impacts how I understand my user's experience. Institutionally, what are the important customs and practices at play in my user's experience? And then what are some of the customs and practices that work together to include or exclude the user? Moving on, the other thing I want to practice and encourage everyone to practice is this thing called appreciative inquiry, or the other AI as it's called. So with this one, obviously we talked about meta-empathy and really reflecting on how is it that we perceive our chosen user group. But another thing to think about is when we think about underserved communities or communities that we call priority populations, the default is to just think about what's missing or what's the deficit. But appreciative inquiry is really thinking about what is the best that already exists. So instead of focusing on the deficit, you think about what's actually available and what are some of the strengths that you can leverage. And so just a little bit of history, if anyone's interested, Appreciative Inquiry was started by a professor of social entrepreneurship, Professor David Cooper Ryder, and he's often considered the pioneer of this model. He worked with his mentor, and they developed this paradigm, which is a little bit different from problem solving in that instead of having the identification of problem and going through that step of analyzing causes and then devising solutions and then applying the treatment, we instead look at what is the best that already exists, and it's a little bit more broad in terms of envisioning what's possible and then starting to put action steps around it. Certainly, appreciative inquiry doesn't mean that it's ineffectual in the sense that it's more blue sky and there's not actual action that's taken. Certainly, you would still apply the steps of creating an action plan and innovating, but it's a really good way to have that strengths-based thinking instead of having this view of let's fix what's wrong. And in a nutshell, it's sort of based in this idea that every human system has a positive core of strengths. So, for example, let's think about Indigenous communities, for instance. Often the thinking might be that we want to fix what's missing. But can we leverage the social strengths? So, for example, if there's a community that's still living in close connection with their land and in close relation with their community and tribe, with their language, then can't we leverage some of those social strengths to then create a model of care around it that's beneficial and culturally appropriate? So with that, I kind of want to talk lastly briefly about sociological imagination, which thinks about let's look at health problems as social issues. And so this was a paradigm of thought which was pioneered by C. Wright Mills in the mid-20th century. And they say that neither the life of an individual nor the history of a society can be understood without understanding both. And so it takes us back to what I was saying before around social justice and injustice, and thinking about how is it that one person's behaviors or actions are being impacted by the society around them and vice versa, and really looking at that balance between systems and individuals to then think about their collective relationship and social structures. So I'll give a small example to wrap up quickly. There's some evidence to suggest that manual laborers have a shorter life expectancy. And so if we were to reframe this issue as a social problem, we might think about what are the historical, cultural, and structural factors which are probably causing or affecting this. So for example, historically, we might like to understand why is it that manual workplaces have been so dangerous? And culturally, is this a workplace that reflects and sort of places greater emphasis on individual responsibility rather than really propagating this preventative safety culture from the top down? And certainly, like, is manual labor often done by men, and who often then experience stoicism where they think, oh, it'll be okay, I don't need to seek help. So is culturally something at play here which then impacts help seeking? And structurally thinking about what is the way work is organized, what is the role of managerial authority, rights of workers, are unions in place which can advocate for worker rights, and the role of the state in regulating these workplaces as well. And so by really reframing health problems as social issues, we are then able to explore alternatives critically and thinking about the status quo and thinking about how we can, for example, increase effectiveness of OHS regulation in this instance. So I want to leave you with this thought. More recently, I've become aware of this term called epistemic humility, and it's very much about practicing an intellectual humility, if you like. So I want to leave you with this quote that epistemic humility is an intellectual virtue, and it's grounded in the realization that our knowledge is always provisional and incomplete, and that it might require revision in light of new evidence. And I think particularly when we think about diversity and diversity within diversity, and practicing reflexivity and having that sort of meta empathy, I think humility is a really strong virtue that should underpin our efforts. So I might stop there and pass it on to the next speaker. And yeah, would love to take any questions. Thank you.
Thank you so much, Mahima. That was just delightful. It's a sobering thought to think that 90% of digital innovations fail. And I do have to say, your avatar was kind of Mona Lisa-esque, dare I say.
That was the prompt that I gave.
I think it was
wondering if
fantastic.
that's inspired.
It looks great. And that appreciative inquiry, that other term of AI, is absolutely delightful. We have diversity and diversity of our social imagination, really, and what's included within that. So thank you for highlighting that. And a recurring theme that I absolutely love is that there are principles and values and virtues to be upheld. And I hope that our listeners today are actually taking that on board, because our principles and often our values are the things that have to underpin our projects, because when we're working with diverse communities within diversity, the principles are the only thing that are constant in all of our work from project to project. So thank you so much for that presentation, Mahima. It was absolutely brilliant. I'd like to introduce Shona Kennedy now. Shona comes from Bathurst, and as you know, she is a proud Indigenous woman who is going to actually talk about some of her diversities within diversities of her own peoples as well. So Shona, I welcome you to the floor. Thanks so much.
Yama, I'll just get my, okay, cool. Yuru Marang, Yuanadi Shona. So I just said, hello, good day. My name is Shona. I am a proud Gamilaroi woman. I do live on beautiful Wiradjuri country, and Walu is Walu Wallawan is the word for Walu is actually Mount Panorama. If you're familiar with Bathurst at all, the V8 supercars, I think I've been once in 40 years. And Wallawan, it means health in Wiradjuri. I am here to talk today just about what I've called deadly recruitment. We've just been funded to get a justice reinvestment site here in Bathurst. We are one of those communities that is probably underserviced in a sense. We have Kelso, which is where our larger population of Aboriginal people live, where the CEFA index is we're 4, but for Bathurst it is much higher. So there's that diversity that we're talking about today, is that within our community in Bathurst, it's actually a have and have not situation to some extent, that, you know, one of the indexes is 4, but the other is, you know, so that means only 4% of Australia's population are worse off, or 4% of communities are worse off than Bathurst, Kelso. But if you look at that number for Bathurst, it's much higher. But Bathurst is in the middle of New South Wales, a couple of hours from Sydney. It's actually a really nice place to live. It's the oldest inland city in New South Wales so it was the first place that was impacted by colonisation, and that impact is seen today. I'll just move on to this slide. So the importance of the acknowledgement of country, I did the one, I did Wharton's at the beginning, but I'll often refer to the 4 women in my life that are most important. And I'm a daddy's girl, so I'll pay tribute to the men in the room, and I've got 3 brothers, so I did grow up in like kind of an alpha male space. But that was kind of scaffolded by all of these fabulous women. So my daughter, who's now 7, most of those photos are a little bit old. The second photo is my maternal grandmother, who actually was born died when my daughter was born, so they were within meters of each other, so that whole full circle thing. My grandmother never lived on Wiradjuri country up until 7 weeks prior to when she died. My paternal grandmother, who is 99 in May, and the last speaker, I'm sorry, Dr. Carla, you know, when you were talking about the health of Aboriginal people, I mean, these systems worked for thousands of years, and I can attest to that, because my grandmother, it worked for her, you know what I mean? She lived a lot on country out at Walgett. She walked everywhere. She had a really healthy lifestyle, and she didn't eat a lot of takeaway food. I mean, they're probably things that all of us could live by a little bit and we'd all be better off. But those practices that were underpinned by her history and her culture, you know, really fared well for her. And other than my grandmother getting cancer, which snuffed her out, my other grandmother, she was actually quite well as well. She lived that same kind of lifestyle, and she died at 82. My mum is the last picture in the photo, who is just a really she's probably the shining light out of everyone in my family. I know that sounds very corny when I say it. She'll always brush that away. She's not someone who's openly, she has no ego about her whatsoever. But the reason I introduced those 4 women is because when we talk about diversity, even with the way that my 2 grandmothers grew up and worked compared to how my mum did and how I did, you can just say, oh, they're all Aboriginal people, but our narrative is all different. And that's not uncommon for all different generations. But the one thing that I think I've been lucky with having such strong women in our lives, and I know that women's rights have been not great, as we've progressed through time. They're much better now than they've been before, and they're probably on a precipice at the moment of not faring so well. But Aboriginal women's rights have probably always been a little bit step ahead in one sense, in their cultural sense, because I always remember my nans leading our families. So they both worked in jobs where they were either underpaid or not paid at all. But the skill set that they got from being treated like that significantly impacted my mum and myself in our roles today. So I just wanted to open with that acknowledgement of what those women did for us to have qualities that we perhaps wouldn't have had if not for colonisation. So I'm not saying that it's a good thing that it happened, but the silver lining is the strengths and attributes and qualities that they gave my mum, who gave to me, who gave my now feisty 7-year-old, are something that I'm really proud of. And I don't think you realise that as a younger person. As you get older and you have kids and you reflect on, you're on the back end of your life, not the front end, you kind of think, okay, what did I learn from my grandparents and my mum? They inspire me to do what I do. Country is obviously very important. I've lived in Bathurst for 40 years. I'm a proud Gamilaroi woman, but I'm very proud to be on Wiradjuri country. And through my daughter's dad's side, she's also a Wiradjuri person. So I'm going to talk about mainstream recruitment, and I did that introduction, which was quite lengthy, to scaffold what I'll be talking about now. In all jobs that I've had, so when we got the Justice Reinvestment Grant, I just thought, yep, I'm going to put these ads out. We're going to get great people. They're just going to come work for us, and off we go into the sunset. And even the ads themselves were from the Justice Reinvestment National Network. So we used those, and they didn't have qualifications in the ad. They didn't say you need to have this skill set or this amount of experience. It was kind of more alluded to community strengths based. But for all jobs that I've ever had, there are your qualifications, what experience you have, and experience means what have you worked, what have you done similar to this role at a job, what are your hours and capacity, particularly women. It's kind of, can you do it all? Can you have a full-time job and raise families and bake cakes on the weekend and get kids to sport? And what are the skills that are needed? So jobs are often prescriptive around the skills that we need. So I even went in with that idea, towards the back end of last year, thinking, oh, yep, I'll put all these things out and we'll just get our 5 staff and off we'll go. And how wrong I was, really. So what I've learned here, which I probably always knew, but I didn't really know until I sort of managed this team. And I've managed teams before, but they were under a very European construct, and it was certainly not for justice reinvestment, which is unfortunately like one of our inherent problems as Aboriginal communities. So Aboriginal community qualifications. I'm really proud to say that all 4 of our full-time staff who do most of the legwork, including myself, all went to Kelso Public and Kelso High School. And whilst you might think, how is that a qualification just going to that one school? It actually is for this particular role, because we all inherently have knowledge of the 2 schools, the systems, how they've progressed. I'm 47, our youngest is 18. And so the difference in that 30 years of what these schools look like, and the other 2 are in between. So we're all about 10 years apart in age. And so we get to see the progression in that school and the progression in the high school. We also have another few part-time people that have had justice issues and know the community. There's one young fella, he's a part-time worker, and he knows every auntie and what they're up to and where they've been and what their kids are up to. And you can say to him, who's that guy in the hat? And he can be, 200 meters away. He goes, oh, that's Bob. That's such and such his son. And his dad's over there and his auntie's in jail. And poor little fella, he's probably just come down here for breakfast. You can't buy that. You can't teach it. You can't get that from a degree. Again, intricate, unfortunately, systems knowledge from overuse or ongoing engagement. The amount of people that would inherently just know how to book an appointment with someone that's incarcerated or because we have a jail in Bathurst is actually pretty scary. The amount of knowledge that kids have around that space to go, oh, yep, you just do this, mum's going to do this, and then overuse of health systems. I was at the hospital last night because Nan took me up there because she doesn't have a car, so we just get an ambulance. So the inherent knowledge that our staff have of those things. I've got I'll talk a little bit about her in a minute. I've got a mum of 7 who we employed at 7 months pregnant. Now, most people might think you're mad, but who better to run a mums and bubs group for Aboriginal women than a mother of 7 who is an Aboriginal woman. She just also happens to be an ex-manager of a bank. So she's actually got a qualification, but that qualification wasn't as important as her being the mum. Oh, I just have to move this screen because it's on this last one. Positively looking at capacity, not as a deficit. I guess that was the segue from that mum. We've got people on our staff and it's their story to tell, but there's drug and alcohol misuse in terms of, or previous drug and alcohol misuse in their background. The mums, I'm not terribly overqualified. I don't have any degrees. I've got certificates and diplomas, and I don't frown on those either. But to manage a justice reinvestment thing, 10 years ago, I would have thought, you probably have to have a degree to do something like that. So looking at what capacity you do have as a strength, not as a deficit. Community and family responsibilities, this is a big one. I think that because we all come from this space, it's very easy for all of us to go, oh, you know what? She just has to run home to do this. And does that really adversely affect the running of our programs? Probably not. So we will all support that as a team and go, right, we need to get this matter fixed. I had recently a young fella who had some legal troubles and was just chucking it all in. He said, I'm going to quit. I'm not going to do this. I'm just going to move home, live with mum and dad, and get on the dole. And I said, oh, actually, you need to relax, right? Like, you need to actually figure out what are the steps. You're not convicted. You don't have to worry about that. What sort of justice reinvestment employment agency would we be if, and it wasn't to do with children, it wasn't violence, he was just really distressed because he'd never gotten into trouble before. And I said, this is probably a really good thing for us to use moving forward. So these are the real life examples that unfortunately for our mob are more apparent than not that we can take to go. We have an inherent knowledge of what it's like to be an Aboriginal person. And it's an understanding that you can't really teach. We can share, and don't get me wrong, I've got, 2 or 3 significant allies for this process that help me that aren't of Aboriginal heritage. And it doesn't mean that there's not a place for anyone in our space, but to run these programs where we can just understand where our mob's coming from that we're trying to help is really significant. So the project outcomes or improved project outcomes that I've seen even in the short time that we have been working is community trust. We've got a couple of old elders who, one lady's got 68 grandchildren and 3 or 4 sons that are continuously incarcerated and back out. And she trusts us to work with her family to do the things that we can to support her and her children and her grandchildren. She comes directly off a mission, so she would have been part of when Stolen Generation was rife. And even not so much actually the stolen generation of babies being taken, but the effects of all of that, the stress that comes from that. So we build community trust, and we do start with our elders. In Bathurst, we have two, well, it's not divided, but there are two significant groups. We have our community elders, which are the people of grassroots. Then we have our Wiradjuri traditional country elders. And the mandates for those two groups are quite different. One's around country and, you know, knowledge around that kind of the cultural aspect of the land. And then the others are the people with 68 grandchildren that look after the babies and mums and others in jails in our community. So community trust, we have an integrity of knowledge. So we have to have tough conversations sometimes with people, you know, but there's no one that can say to us, oh, you don't know what I'm talking about, you don't understand. And although we might not have that exact circumstance in our space, we're all impacted by the issues that affect Aboriginal people in the Closing the Gap space. So we don't often hear, oh, you don't understand, which I know that some of our mobs say to other service providers. Our ability to pivot in programming is significant. Actually, we've changed a few things really quickly because we can make that decision without having to go through all of that red tape to say, hey, you know what, can we change this day to this day because it best suits our mob? We can actually decide as a team on a Wednesday afternoon at 3:45 that Thursday's got to look like this because it just has to. We have had a young fella, you know, pass away in the jail recently, and, you know, if we have to pivot because of those sorts of things, and that's what we have to do and we're mindful of, the load is carried equally. So it doesn't matter around what your qualification is or what your title is. We all take the load home equally, or we all say, you know what, I'm going to carry this one for you today, which can sometimes be lost in mainstream systems because it's like, oh, well, that's the manager's job. You're the only one that needs to take that home. We choose to carry that equally. There is still delegation, obviously. There's delegation that I have to carry more than what my other staff would. But in terms of us caring for mob, it's all carried equally. And, yeah, reciprocal respect so that, you know, our community respect us as well. The only other thing I wanted to mention about Mundungu, which is thank you. The only other thing I wanted to mention about diversity, Leslie, before I move on, is identity is so fluid for Aboriginal people. So you can't just think, oh, well, you know, Shona's Aboriginality is the same as even my brother's. There's 13 years between my brother and I. So how would my story be the same as his? So often we'll go, oh, yeah, we'll just employ an Aboriginal person and they're the right person for the job. And that often might not be the case. But I'll get to question time. I hope that helps people think about, you know, breaking down that narrative. We're lucky we're in an Aboriginal community controlled space, so I have the freedom to do that, to look at what I need to remedy, not what jobs do I need to fill. And bureaucracy isn't like that just yet. Thank you.
Thank you so much, Shona. That was fantastic.
Thanks.
You come from an amazing line of women, I have to say.
Yes.
So that's a lovely acknowledgement, and the fact that your qualifications are different to what Western world thinks qualifications are, that community qualifications are worth their weight in gold in your community and how you operate, and indeed that is the diversity within the community. Is the qualifications, the qualifications you talked about, that fellow who knows absolutely anything and everything, which is the diversities within your own community, is just fantastic. And there's a recurring theme there towards the end, which you said, which was about reciprocity. And this is that recurring thing that we all have to say, that we're all here to learn from each other. Yes. Which is a beautiful message to finish off with. Thank you so much. I'd like to invite Jeanette Purse to join us in this panel Q&A discussion at the moment. But I do have a question from Sarah Lukman. Thank you, Sarah, for joining us. And this question is for Rosalie. It seems by working hard to reach people with a disability and non-cisgender, you've also managed to reach an incredibly diverse group of people who are often not reached through normal research processes. Example, 10% of Aboriginal and Torres Strait Islander, 23% of regional. Why do you think this might be the case?
Thanks for that question. Oh, yeah, that's a good question. I guess two things that come to mind is early on in the project, and I think this was thanks to a workshop that Wharton facilitated. We had to think about who's not in the room and why. And then we worked to make it a safe and accessible space for those people to be part of our advisory group. And so I think that means that our approaches are really, it's slow going, but it really considers a whole range of different perspectives, and we're really careful with the materials and approaches that we're using. And I think that that has the benefit of, yeah, reaching these communities that we wouldn't otherwise.
Yeah, Rosalie, you
Yep,
just
so
used a beautiful word there, which is slow. And we've got to hurry up and be slower. And I do love the saying, which is move at the speed of trust. And for some, it's enormously slow, and we have to move at that pace in order
yeah,
to get the richness that you're getting at the moment. So
yeah,
yeah.
yeah, absolutely. It's a lot of individual relationships and group relationships, and also group identity as well, people rallying together to work
Yeah.
on this. Yep.
Yeah, and I think this whole thing of bringing consumers into the space right from the very beginning, whilst it gives us beautiful data and helps us design things that are more community relevant, it becomes a place that is relational as well as transactional. And I think far too long in health, we've had it unweighted with it being transactional. And so this evens it out, and it's a beautiful approach. And Mahima talked about that lovely balance between the two, which is really nice. Jeanette, can I bring you into the discussion if you have any questions or comments about what you've just heard so far?
Yeah, no, thank you. Thank you to all presenters. I think an incredible webinar so far in just showing us the value and the importance of looking for diversity and how we can actually access it, but what we get from that, what diversity brings to the richness of our research that we wouldn't have otherwise. But I'd like to just add another comment to Rosalie's observations, which is and I think, Leslie, you've already reiterated this or made comment on this on Rosalie's project, is that the co-design was there from the very outset. And I think that is critical. But it's not just any co-design. I think you really do need to think about who's at the table. And Rosalie, I know there were some people who were approached who weren't available or who didn't feel that they were comfortable in this, but people then made referrals to other people. There were organisations that may look by their name that they're appropriate, but when you dig a little bit deeper or have some conversations, you realise that they may not have the same sort of breadth or reach. Because of most of the time it's because of structural sorts of factors, but spending a lot of time making sure you've actually got the right partners, I think is really important, and that is also part of the slow process. But it also comes with a lot. That there also is something that you have to be aware of, that in these highly contested spaces, it's not unusual to have people who have differences of opinion, not just diversity in who they represent, but also differences of opinion. So you've got to create that space within the research project, within the governance structure, that actually that can respect and those differences of opinion, and for differences, especially between groups. And I think that's been something that Rosalie and the team have spent a lot of time doing. I think that's sometimes where it becomes difficult, because people will gravitate to one group that represents one set of views, a bit fearful of including others. But I think if you can find a space where you can actually represent that diversity of opinion, not just diversity of experiences, that also helps.
Yeah, and I think that smacks of why our principles are so important. I mean, the NIHR principles go a long way to address that as well. Reciprocity is one of them, but it also says that everybody's opinion is equal and valued, and that's exactly what you're talking about. That it's, it goes back to that, was it Voltaire who said, I might not agree with you, but I'll defend your right to your different opinion to mine, or whatever it is. Yeah, it smacks of upholding the principles in the space that you're working in all the time, and also have the courage to defend those. And I think every speaker has spoken about how important those principles are, and how important it is to pivot and take on differences of opinions and or aspects of your work. So I need to wrap it up now. It's 3 o'clock. So just in about 7 days, this video will be online on YouTube. So you can find if you want to rewatch it, or indeed share it with others that missed out. We've got an upcoming webinar in June, which our CCI subcommittee will deliberate on in terms of the subject matter and the speakers and all that type of thing. And also, to conclude, right after this webinar, there is a quick survey that will appear when you go out of the webinar. So we strongly encourage you to complete it. It's so fast. It's a multiple choice question thing, and it might take you 1 to 2 minutes to do, but it really helps us improve on the webinars, but also helps us deliver information that you're really interested in knowing about. So can I thank Shona and Rosalie and Mahima and Jeanette. Thank you so much. And Amy in the background for making this all happen today. I thank you so much for joining us today. And I wish you all a good day and hope that this was informative and useful. Bye for now. Take care.
Thanks.